Welcome to ACR On Air, the official podcast of the American College of Rheumatology, where we have engaging conversations with leading rheumatology professionals on topics such as the latest research on rheumatic diseases, solutions for addressing practice management issues, legislative policies impacting patient care, and more. Here's your host.
People with rheumatic diseases have increased rates of vaccine-preventable illnesses such as pneumococcal disease, influenza, and herpes zoster as compared to healthy controls. Unfortunately, studies also show that both children and adults with rheumatic diseases are under-vaccinated. Some studies I saw suggest that up to 40% of patients are still missing important vaccines. Now, the topic of vaccination has become increasingly polarized in the age of COVID-19. Nevertheless, there are still valid concerns about providing vaccines to patients with rheumatic disease, many of whom are immunosuppressed. Will vaccines trigger a flare of the patient's rheumatic disease? There's also uncertainty regarding achieving adequate immunity among this patient population. And for live vaccines, there's the question of whether they should be given at all while the patient is immunosuppressed. Even if one decides to be vaccinated, there are questions regarding the timing of the vaccines. Should they be given when the patient is flaring? Should their medications be held around the time of vaccination? Should the doses of steroids be decreased before providing a vaccine? Also, who's responsible for vaccinating people with rheumatic disease? Is it the pediatrician, the internist, or the rheumatologist? Fortunately, the American College of Rheumatology has recently released the 2022 Guideline for Vaccination for patients with rheumatic and musculoskeletal diseases. To help us disentangle some of these complexities, we've invited the study's lead author, Dr. Ann Bass. Dr. Bass is an attending physician in the Division of Rheumatology at Hospital for Special Surgery and a professor of clinical medicine at Weill Cornell Medicine. She specializes in the treatment of patients with autoimmune side effects of cancer immunotherapy and sees patients with inflammatory arthritis, vasculitis, and other autoimmune conditions. Enjoy the show. Anne, welcome to the show.
Hi, John. It's great to be here.
So, this is the first time that the ACR has developed guidelines on vaccines. It used to be that guidelines related to rheumatoid arthritis would have at the end a little block over where they talk briefly about vaccines. But this is the first time that the ACR decided, no, a whole guideline on vaccines was necessary. And not only that, they also decided to combine pediatric and adult vaccines in one guidelines. What was the thinking behind that?
Yeah, John, you're exactly right. We've never done this before, but I think a few things happen. So first of all, let's say you're creating a guideline for rheumatoid arthritis. That little vaccine paragraph that was going to be tacked on the end, I think people began to realize there's a huge literature out there and lots of issues related to different medications, for example. And there was also a recognition that a lot of the issues are shared across diseases. So we use a lot of the same medications in different conditions. And that also these issues are shared across populations, including adults and kids. And so the ACR decided that it makes sense to pull this topic out and look at it globally and include both adult and pediatric rheumatologists and try to, as much as possible, create a set of guidelines that crossed over populations, age groups, and disease types.
Yeah, I guess that makes sense because, in a sense, if you're immunosuppressed with RA or lupus or anything else, the guidelines are probably going to be very similar rather than having different guidelines for different diseases.
Exactly. Some conditions may themselves predispose patients to a slightly higher risk of infection more than others. For example, lupus is thought potentially to increase infection risk, whereas perhaps RA as a disease unto itself does not. But the big issue with our patients are the immunosuppressive agents that we use to treat them, and those really are used across patient populations.
Got it. And I guess one caveat of the study is that COVID-19 vaccinations was not included.
Right. And I think that's a lot of people will be asking questions about that. So as you know, we had a task force. I was actually a part of it to create a guidance document last year. And as you also know, the literature on COVID is so vast and so rapidly changing that even with the guidance document, we had to update on a regular basis just to keep up. So the concern was that if we included COVID, since the process for guidelines as opposed to guidance documents from the ACR is a long process, that really by the time we publish this, everything that we wrote would be out of date. And so the way guidelines work at the ACR now is that they're considered to be over the long-term living documents, and there's an automatic plan to update them at regular intervals. And so we will certainly be updating this guideline at a later date. And at that point, when the pandemic has stabilized, as it is beginning to, I say hopefully,
Hopefully.
we can have some recommendations regarding COVID vaccination and medication management at that time at a later date.
Fantastic. Yeah. So we've actually discussed in previous episodes about the COVID vaccines. So it's good to know that for COVID vaccines, we should refer to the guidance separately. And for all the other vaccines, we should look at this manuscript.
Yes, that's absolutely the case. But I would also say that the CDC is probably your best source for up-to-date guidelines on COVID vaccines, because even within a few months of the most recent COVID guidance document, things have changed. There are new vaccines coming out. So for really up-to-date, I would refer to the CDC website.
Fantastic. Thanks for that. And we'll put links to all of these documents on the acronair.org webpage. So tell me a little bit about who made up the panel that created these guidelines.
So there actually are a lot of panels. Creating a guideline is a work of many, many, many people. So the core team is the team that really created what are called PICO questions. That is, what are the questions that we really want the guideline to address? And PICO stands for the patient population, the intervention, and what the outcome is. And that list of PICO questions is what guides the literature review. So there's a core team that creates the overall structure for the guideline, the topics to be covered. And then there's a separate literature review team, a large team of wonderful rheumatologists to whom we are very grateful, who read through a massive amount of literature and extracted it to create an evidence report that then the core team was able to extract from, review. There's then a meeting, really a 2-day meeting, where a third panel called a voting panel of rheumatology experts come in and under the kind of the leadership or guidance of the core team, review all of the PICO questions and review the literature and vote on what the recommendations are going to be. So there are those three teams: core team, literature review team, and then the voting panel. And everybody gets to look at all of the drafts of the manuscript, and there are lots of other layers of review as well. But it's really a host of people.
And were patients involved in this document?
Absolutely. And sorry for leaving it out, because that was an incredibly important piece of all of this. So there was actually a patient panel, and they met separately to review the kind of preliminary recommendations and were kind of the preliminary questions that the voting panel was going to discuss to give patient perspective. And there were very careful notes taken at that meeting that were brought up at the time of the voting panel meeting. And in addition, 2 members of that patient panel served on the voting panel. So we had patient representation, which was incredibly important, and their perspective is very different from, needless to say, very different from those who were on the treating the physician side. So they were, a very important part of the whole process.
Yeah. And then for these guidelines, you probably had also pediatric rheumatologists, adult rheumatologists, you have the patient panels. So was there any controversy among you guys when thinking about these guidelines?
I won't say controversy, but I think that it was really helpful to have the pediatric perspective, because there were issues that those of us like me who are adult rheumatologists just weren't aware were incredibly important issues for the pediatrician. So a lot of the discussions around live vaccination, as an adult rheumatologist, It's very rare that my patients need to get a live vaccine now. Maybe yellow fever if they have to travel abroad. Now we have a non-live shingles vaccine, so we don't have to give a live, zoster vaccine anymore. Maybe somebody needs a measles booster, but it's really pretty rare. But in the pediatric population, live vaccines are a major part of the primary and booster vaccination series, measles, mumps, and rubella, varicella. So this is a major issue for them. They also have to address issues of in utero exposure to medications. So there was lots and lots of discussion and a little bit of debate over how to, what recommendations to make about medication continuation or discontinuation holding around the top of live vaccines. So that was probably the most lively debate and back and forth that we had.
That makes sense because, most of the paper, I guess, deals with killed vaccines, whether it's influenza or pneumococcal. And for live attenuated vaccines, I think the recommendations are generally don't give them on patients on immunosuppression unless you hold the immunosuppressive drug and then wait a specific period of time.
Right. So that was the question, the PICO question that we had, should you hold immunosuppression? And so in an attempt to be as safe as possible, that was the broad recommendation. But we realized, having made that recommendation, that you really had to get into the nitty-gritty of each particular medication and each kind of scenario where a live vaccine might need to be given. So although the broad recommendation is to hold immunosuppression, there's actually a pretty detailed table in the guideline which outlines exactly what to do with every type of medication. And then there are about 5 footnotes to that table that allow for exceptions when they're needed. And you mentioned children with autoimmune or autoinflammatory conditions. I think where this comes up the most or is most problematic is in small children who have autoinflammatory disorders and require IL-1 or IL-6 inhibition and haven't yet gotten their primary vaccination series. Because the risk of, when you talk about live vaccines, what your worry is vaccine-induced illness. It's not an issue of effectiveness, it's an issue of getting sick from the vaccine itself. And viremia or vaccine-induced illness is much less common when you get a booster than when you get the primary vaccination, because with the booster, you've already gotten some exposure to that antigen. You have some immunity. Viremia is there's not as much viremia and it doesn't last as long. So the risk is lower. So in the kind of the older school age kids, they've received their primary series. We might be talking about a booster and the issue is a little bit less acute. But when you're talking about those really little kids with autoinflammatory conditions, they've never been exposed to these antigens. And they're at very high risk for disease flare. And these can be really severe disease flares if they hold their medication. So, for example, one of the footnotes is that, in a child who has, say, an autoinflammatory disorder where the risk of holding medications is very, very high, that shorter durations of holding the medications is permissible and that you just have to have a long conversation with the parents or the guardians, and in that instance, obviously it's not going to be with the baby, so that everybody is on board and understands that there is some risk associated. But more importantly, the family understands what the symptoms or signs of vaccine-associated illness might be, so that they know when they need to bring the child in for evaluation. So that was something that wasn't, not something that's at the top of my my day-to-day routine, but it's very routine for pediatric rheumatologists.
Fantastic. Now let's get a little bit of the highlights as to some of the specific vaccines. So influenza vaccines, certainly it's recommended for everybody in general, and especially people on immunosuppression. Are there specific things we should be thinking about among our patient population regarding the influenza vaccine?
Yeah, absolutely. I mean, I guess influenza is, there are a couple of things about influenza. As you said, it's recommended to everybody. The other thing about influenza is that it's a seasonal vaccine. So timing matters. And that's really why in many cases the recommendations are different for influenza than they are for some other vaccinations. So for influenza, because it is time dependent, we really recommend it for everybody, no matter what medication they're taking, what dose of steroid they're on, if their disease is active. just give it, because the biggest worry, and I would say a guiding principle behind our guideline, is that patients should receive indicated vaccines. And that when you don't give a vaccine, when you hold it, that's a missed opportunity. And it's been shown over and over again that when you hold, and it may be very well meaning, you want to give it at a later time point, that about a half of the time, those vaccines never get given. So generally better to give the vaccine, except with a few exceptions. So influenza vaccine, easy answer is to give. And then we did also, of course, address, the form of influenza vaccine, regular dose, high dose, adjuvanted vaccine. And, as you know, the CDC has recommended adjuvanted or high dose vaccinations in individuals who are over 65. But we did recommend that they be given to patients with rheumatic diseases over 18 who are on immunosuppression, just to maximize vaccination responses.
Yeah, so that's an important point because, if you tell, a 20-year-old, go get a flu vaccine, and they may be on a TNF inhibitor, they're probably just going to get a standard dose vaccine, whereas they may qualify for the high dose or the one with adjuvant. That's an important recommendation that actually I didn't know.
Right. And that is really a new recommendation. That is not something that's been recommended before. And a couple of important points, I think. People are concerned about insurance coverage.
Yeah.
So we want to make sure that insurance coverage doesn't stand in the way of vaccination. So again, getting back to what I was saying before, getting any vaccine is better than no vaccine. So if you don't have high dose or adjuvanted vaccine in your clinic, give regular dose. That's better than waiting and having them come back at some later date for a stronger vaccine.
That's a great point. So if you have your patient there and you have any flu vaccine, just give it to them, because some vaccine is certainly a lot better than no vaccine.
And this came up also with regard to just one other thing about influenza, with rituximab, because rituximab does reduce responses to vaccines in general, including influenza vaccines. So once again, with regard to flu vaccine, since it is a seasonal vaccine, we recommend just giving it regardless of when the patient got rituximab. But you could always revaccinate. So, for example, if the patient got their rituximab 2 months ago and you give them a flu vaccine in October, you could potentially vaccinate again in January or February. And same with other vaccinations.
And I guess there's another issue in terms of medications related to influenza vaccine, which is methotrexate, and what we should do with the methotrexate.
Right. So this is one of the few areas where we have randomized controlled trials, which is wonderful. So there are, I will say, not only randomized controlled trials, but numerous observational studies that do show that methotrexate reduces the effectiveness or the immunogenicity of flu vaccine and really many other vaccines as well. Here, what we do have, though, are randomized controlled trials looking at the effect of holding methotrexate. And it seems that actually holding methotrexate for 2 weeks after vaccination, it's a little bit counterintuitive, not before, but after vaccination, improves vaccine responses. Once again, though, it's not like patients who stay on their methotrexate don't have any response to flu vaccine. So if you have a patient where you're really worried about holding methotrexate, then continue it. So the recommendation really is to hold methotrexate for 2 doses after the flu vaccine, but really only if disease activity allows, not in somebody who's unstable.
That makes a lot of sense. Talk to me a little bit about pneumococcal vaccination. So there's 2 vaccines, the conjugate vaccine and the polysaccharide vaccine. Who should receive what?
So we have recommended, so pneumococcal vaccination is recommended to individuals over 65. We have strongly recommended vaccination to individuals who are 18 or over on immunosuppression. And that actually is not a change. The CDC already recommends patients who have, quote, certain medical conditions, which includes people who are immunosuppressed, that they receive pneumococcal vaccine. And the American Academy of Pediatrics also recommends pneumococcal vaccines to kids under 2, and then for those over 2 who have, again, certain medical conditions. This is not really a change, but it's an emphasis so that rheumatologists remember and make this recommendation that really is already in place. Now, with regard to what the regimen should be. This is one of those moving target topics. So currently in adults, we recommend the conjugate vaccine and followed by the polysaccharide. However, the new conjugate vaccine 20 with 20 antigens is going to be coming out very shortly. And that will really obviate the need to do 2 different doses because the polysaccharide vaccine has 23 antigens. This conjugate vaccine will have 20. It's pretty much covering the same spectrum of variants. And so pretty shortly, the CDC is going to be recommending just PCV 20, and that will be what everybody gets. So I recommend that people look at the CDC website, again, for the specific regimens that are recommended. But whatever the regimen for the age group, just give that one to pretty much all of our patients who are on immunosuppression.
Fantastic. New vaccines. I love it. I mean, with
Yeah.
the development of Shingrix, with all of the COVID-19 vaccines, it's like, really booming this using vaccinations. Speaking of Shingrix, now you recommended Shingrix for all adults. Is that right? On immunosuppression.
All adults on immunosuppression, yeah. And that actually is another one where the CDC recommends patients over 18 who have certain medical conditions, including immune suppression, that they receive Shingrix. So that's one I think pneumococcal vaccine people are a little bit more attuned to, but giving Shingrix to younger people is not something that most rheumatologists think about. So that I think will be a little bit of a surprise to people. This is a vaccine that can cause, some what we call reactogenicity, meaning arm soreness, achiness, a little fever. So that's just something to be aware of. There may be slight increased risk of flares. One study suggested that. And I will say that in all of these recommendations, the major concern that our patients have is that getting a vaccine might induce a flare. And I just want to say that the literature review really didn't suggest that there is any significant risk of disease flare with any of these vaccines, with the slight exception possibly of Shingrix, a slight increased risk of flare in one study.
That's interesting. So we've done studies in COVID-19 vaccines and also didn't really show an increased risk of disease flare after getting the vaccine. It seems like, I guess, with Shingrix, that may not necessarily be true. Although if you've ever seen anybody with shingles, you'd certainly want to try to prevent that because it could be pretty painful for a lot of people.
I think we've come a long way. I'm a lot older than you, but when I was a fellow, we were worried about giving any vaccine to our lupus patients, and it really took a while for the field to kind of recognize that the flare risk was low, and more importantly, that our patients are precisely the ones that really need protection from vaccine preventable illnesses.
And then just to touch on HPV vaccinations, you're recommending that for young adults if they haven't already had it. Is that right?
Exactly. If they haven't been vaccinated, as is recommended in kind of the middle school years or in high school or college, we recommend that they be vaccinated. Well, it's a conditional recommendation, but so that it be discussed with them up to the age of 45. After 45, it's not that there's any risk associated with the HPV vaccine, but rather that most people have been exposed to HPV by then, so the benefits wane. And we do know that the risk of HPV is higher in patients on immunosuppression. That's been shown particularly in lupus patients, probably because the lupus patients tend to be young, sexually active young women, whereas other conditions affect older people, where it's a little bit less of an issue.
The last sort of vaccine that you guys addressed was rotavirus vaccines. So I guess, it used to be that if an infant was exposed in utero to TNF, the recommendations were generally to defer live vaccines like rotavirus vaccines until, I guess, after a year. And now the recommendations are it's okay to give it within the first 6 months of life.
So with the TNF inhibitor, this is one that pediatricians on our panels were really grateful for because the CDC or the ACP really have this blanket recommendation not to give vaccination to live vaccines to infants who have had any in utero exposure to any biologic. Yeah. But we know that biologics are different. So what's different in this in our recommendations is that kids whose moms received TNF inhibitors in utero do not need to delay rotavirus vaccine. Vaccine is usually given at 2 and 4 or 2, 4, and 6 months of age. And, if you've gotten infliximab, which is really the longest acting of the TNF inhibitors, it really will be out of mom and baby's system by 2 months. And there's really no need to delay. And there's very little, at least in the case of infliximab, very little drug in breast milk. So there really seems to be no reason to postpone. The argument against postponing is that there's a slight increased risk of intussusception in babies who get rotavirus vaccine late after a year. So in the case of TNF inhibitors in utero exposure, we don't recommend any delay. With rituximab, however, we know that babies who are exposed to rituximab do become B-cell depleted. And so we did have a concern both that the vaccine might not be effective and that there might be some risk associated with it. So in that case, we did recommend postponing until after 6 months of life, even understanding that the delay might slightly increase the risk of intussusception. That risk is extremely low.
Great. Now, switching gears just a little bit. So we talked first about the specific vaccines, and we mentioned in passing a little bit about the medications. But now sort of looking at the medications in and of themselves, it seems like regardless of what medication you're on, you should get the influenza vaccine. And if you're on methotrexate, delay it. For other medications such as TNF inhibitors, should we alter our vaccine regimen? Should we hold TNF inhibitors and when we're giving other vaccines?
Right. So the recommendations are not to make any adjustments in any medications other than methotrexate for any vaccine. So the one exception is methotrexate following influenza vaccine. We recommend holding for 2 weeks if disease activity allows. All other medications we recommend continuing for other vaccines, non-influenza vaccines. And so all other medications and all other vaccines, we recommend just continuing the medications. And that's because we really don't have any good data to support holding. And there's some evidence that the impact on vaccine responses is not great. And there's also a bias in favor of simplicity. But the major reason was that we really don't have good evidence to support holding. And I want to make one comment about the COVID vaccines, because COVID vaccination guidance document, because the recommendation just to continue all of these medications is different than the recommendations in the COVID guidance document, where we had all sorts of recommendations to hold various medications for different periods of time before or after vaccination. And the reason for those recommendations at the time they were made for COVID vaccines was that this was a virus that the population at that time had never been exposed to. So we had a completely naive population at risk for something that was in many cases fatal. And so the onus was on really maximizing vaccine responses. And even in the absence of data, we wanted to do everything we possibly could to make sure that the population would become immune. And so we used theoretical data and what little data kind of accumulated to make those recommendations for holding. That is not the case for people getting flu vaccines, pneumococcal vaccines, things to which we have immunity already. And I suspect, I can't predict because this will require a whole new voting panel, et cetera, that down the road, when much of the population has been vaccinated to COVID and we create recommendations down the road, we may well change the recommendations to hold medications, because those will be in essence boosters, 4th, 5th, 6th boosters, and the concerns will be very different.
That's a great point. What about prednisone? Because, in some patients that are on high doses of prednisone, I think the influenza vaccine should still be given. How about if you're on 30, 40, 60 milligrams of prednisone, what should we do about other vaccines?
Right. So it would be wonderful if there was some magic cutoff with prednisone where we knew that vaccine responses were impacted. It seems that high dose does impact vaccine responses, low dose less, but that there's really a kind of a dose response. There's no magic cutoff. The studies usually, many of them will use 20 milligrams as a cutoff, above that being, quote, high dose. So what we recommended was that in patients who are on high dose prednisone, that you postpone vaccines other than influenza. Again, influenza, timely, seasonal, we recommend giving it, but all other vaccines, we recommend postponing the vaccine until the patient is on a lower dose of prednisone. Now, there are exceptions, and again, this is often in the pediatric population. Kids need vaccines to go to school, for example. And so if you have to vaccinate for that reason, that's fine. Just, go ahead and do it. It's not usually an issue of completely blocking responses. It's just that the vaccine responses may be, a bit less. Below 10 seems to be okay. And then we had to struggle with this range between 10 and 20, for which there really is no literature. So that was another one we tore our hair out over. But we ended up using really the cutoff of over 20, over 20 or 20 and over as being the what we consider to be high dose, leading to postponing the vaccine.
Got it. So if you're on prednisone 20 or above, then you should delay vaccinations except for the influenza vaccine. If it's under 20, you could probably receive those vaccinations. So there's another medicine we haven't discussed much is rituximab and what to do. We actually had our previous episode where we discussed rituximab in the setting of COVID vaccines. How does the use of rituximab affect vaccinations in other vaccines, in routine vaccines?
We actually have COVID to thank for a lot of focus on this issue and a lot of studies that probably wouldn't have been done otherwise. But there's a lot of evidence that rituximab impairs responses to pretty much every vaccine. So when vaccination is more of an elective decision, we do recommend postponing vaccination until the next rituximab dose is due, and then holding the rituximab for a couple of weeks to allow a response to the vaccine. Now, I will say that many of us who take care of patients on rituximab know that even at 6 months, many patients still don't mount a good immune response. I think we were learning that from COVID, but we don't want to wait forever. And there's probably some T cell immunity developing even if we can't measure antibody responses. So the recommendation is to wait basically until the next dose is due and then push off the rituximab if you can for a couple of weeks to maximize your response to the vaccine.
Great. So
any vaccine.
Yeah, that seems similar to the guidelines with the COVID vaccines and
Right.
rituximab. Great. I think another concern that patients have, you mentioned, the first one, which is it going to cause a disease flare? And in most of these vaccines, it seems that that's not the case. The second question they often have is, can I get more than one vaccine at once?
Yeah, I think this is a worry that a lot of patients have, that it might induce a flare. There really isn't evidence that occurs. And once again, in the interest of getting the vaccine and not missing that opportunity, we do recommend that if patients need multiple vaccines, that they be given on the same day.
Great. That's good to hear, because often they have to make appointments for vaccines, and it's much easier to get several at once rather than spacing it out and getting each at a different date. Great. So you mentioned some recommendations that may not necessarily be approved by insurance companies, such as giving Shingrix in young adults, giving high dose influenza vaccine in people under the age of 65. Do you have recommendations about if we have the time to help patients receive these vaccines and get it covered by insurance?
Yeah, I mean, again, just to repeat what I said before, if there's any concern or if the patient has a major concern, give the regular dose rather than worrying about the potential for them to get a bill.
Okay.
But I think that this guideline itself will be a great tool to use. Write a letter to the insurance company, attach the link, and that's about as good as it gets in terms of evidence, to support what you're doing. So that would really be my recommendation.
Fantastic. And I think the big sort of elephant in the room that I see is that all these guidelines are fantastic. And it would be great if automatically every patient that qualifies to getting a vaccine gets the vaccine. But there's so many challenges about giving patients vaccines, because when they come, to our clinic, we carry the influenza vaccine and that's it. When I'm recommending pneumococcal vaccine or Shingrix vaccine, they have to do that elsewhere, either with their primary care doctor, in a pharmacy. We have to make sure that they get it and that we record it. And, primary care doctors may not be familiar with these guidelines and they may not understand that additional vaccines are needed. Do you have any recommendations about how to systematize the process of vaccinating people with rheumatic diseases when, there's many studies out there that show that they're by and large under-vaccinated?
Yeah, that's an incredibly important point because, we can make all the recommendations we want, but if it doesn't happen, the patients obviously don't benefit. So I think there are many steps and many ways that can be addressed. So the first is the rheumatologist has to think about it. Pediatricians are very used to thinking about vaccinations. Adult rheumatologists probably less so. So, whatever system is used, whether it's part of your electronic medical record or you create a kind of a macro or a smart phrase for your notes to kind of keep track of what vaccines are due when. That's a good way to remind yourself that something is indicated. And like you, we stock influenza vaccine, pneumococcal vaccine, but beyond that, we don't. I will say we have COVID again to thank for the ability to get vaccines in pharmacies. That might have been available for flu vaccines, but, in a limited way. And now you can get more and more vaccinations in the pharmacy, which I think is really fantastic. So one thing that we can do is actually order the vaccination and they can get it in the pharmacy. So that kind of gets around the need to communicate with the primary care physician or with the pediatricians usually in the context of pediatrics give those vaccines. So that's one option. The other, of course, is to directly communicate by email, by letter, by phone call with the primary care physician or write a little note that you give to the patient that they can bring to their doctor. That's obviously less satisfactory. It also reminded me that, just back to the rotavirus discussion, that's incredibly convoluted because we're talking about vaccination that's given to an infant by a pediatrician and recommendations being modified based on a drug that the infant's mother received during pregnancy. By the time the infant sees the pediatrician, she's no longer pregnant.
Yeah.
So your point is incredibly well taken, and that's the most extreme example where it's important to actually have that discussion with the pregnant patient while she's pregnant to discuss the impact that the drug she's receiving might have on vaccine protocols for the baby when the baby is born, that the parent should have a discussion with the parent / guardian, should have a discussion with the pediatrician to be really at that time when you're having the conversation. Because if you wait, after the baby is born, there are a million of other things that people are thinking about. This is going to be low. The likelihood of them remembering it is very low. So having that conversation with the pediatrician to be at that time is really probably the most important thing to do, because otherwise it's unlikely to happen.
Yeah, that's great advice, especially now that I think we're becoming a little bit more accustomed to prescribing biologics during pregnancy, whereas before it was a big no-no. Now we're saying, well, in some cases, it may actually not be so bad, and it may be better than other medicines we would give, or certainly would be better than if the mother were to flare during pregnancy.
Right. Particularly TNF inhibitors, yeah.
Yeah. And I guess, you mentioned that certainly vaccination is important to our patients because they're at increased risk of vaccine preventable diseases. But I guess we also have to remember that vaccines are also a public health measure, right? And in addition to protecting our patients, we're actually helping to protect, their families and their communities, their schools, their workplaces. So it's not just for the patient, but for the community at large that these vaccines are important.
Absolutely. And there's actually a question that comes up sometimes is, especially for kids who are on immunosuppression, or not just kids, but is what should their family members do? Should their family members, for example, receive live vaccines if they are in the same household with one of our patients who's immunosuppressed?
Yeah.
And the recommendation is that they should get all of their recommended vaccines, because the worst thing would be for them to actually get the illness. We don't want somebody with chickenpox or measles at home with an immunocompromised patient.
So what I've heard it referred to as like the cocoon, right? That everybody in the
Right,
family gets
right.
vaccinated with the appropriate vaccines to make sure that the child or individual who's immunosuppressed is protected.
Even if the vaccine is a live vaccine, correct? Yeah.
Great. So this sounds like a lot of work that you guys have done. In previous episodes, we've interviewed, lead authors from other guidelines, and they always mentioned that it was a lot more work and it took a lot longer than they expected. Was that the same for these vaccine recommendations?
Oh my God, yes. Uh, yes, it was a mountain to climb,
Yeah, I can
and a lot
imagine.
of literature, 1,000-page evidence report to
Oh my goodness.
incorporate and absorb and try to summarize and create recommendations and encapsulate in what may seem like a very long document to readers, but is very pithy compared.
I can imagine. So with all that literature that you've reviewed, are there specific questions that remain and things that you think, should be answered by anybody out there interested in research? Like where do we go from here? What are the questions that still need to be answered?
Yeah, absolutely. I mean, the striking thing is, despite the 1,000 pages of literature review, most of the literature is very weak. There's limited evidence to support many of the questions that we ask. So, one of the things that's come up around COVID, but really applies to other vaccinations as well, is we don't, for many vaccines, we don't really even have a good measure of effectiveness. We can measure antibody levels, but to what degree do they correlate with
That's a good
actual
point.
protection? So
Yep.
we could need standardized outcome measures and kind of standardized trial designs for testing the effectiveness and safety of vaccines. And there have been a couple of studies where vaccine studies have been tacked on to randomized controlled trials of medications, say for rheumatoid arthritis. And that's a very nice way to kind of do, it's a 2x2 factorial design. You
Yeah.
get answers to two different, very, very different questions. There really are no studies of live vaccines in kids and how to manage those safely. So that's incredibly important. Questions about vaccine-induced disease flares that
Hmm.
patients are so concerned about with, say, Shingrix or with high dose or adjuvanted flu vaccine. And then, the big question everybody wants to know is, what should we do with medications around the time of vaccination? Should we hold them? Should we not? And, we have examples of some nice studies done with methotrexate and influenza vaccine, but we need more studies like that for other vaccines and other medications.
Fantastic. And you mentioned that this was a living document that would be updated. So what is the process of updating? How will that happen?
Right. So the literature, the questions for the literature review, are in a structured format, and the literature review will be updated at intervals. And when at an interval when it is decided that there have been enough changes to make the guideline incorrect or where there's a need to add to it. For example, when we feel that we're ready to add COVID vaccine guidelines to it, that then it will be updated. Many guidelines have had a 5-year lifespan. It's only been in the last 5 years that this living document concept has been embraced by the ACR. And I think there's there's some areas where there were questions that weren't asked that we realized in the process, we wanted to ask. And COVID vaccination obviously is the big hole, but for those we'll have new PICO questions.
Great. And I'm sure you're so excited about heading that process again 5 years
Right.
hence.
Right.
Great.
Yes, I am.
And this has been a wonderful conversation. And I hope that this document and certainly this podcast helps rheumatologists, both, in the pediatric and adult world, recognize how important vaccination is for our patients and provide, some structure about who needs what and discussed, very nicely about how to make sure that that actually happens. So thank you so much for the efforts that you put into the development of these recommendations. And thank you for your time here today.
Thank you so much for having me. And it's been a fun process, a lot of work, but really a lot of fun as well. And I've had great, great colleagues to work with along the way, and it's been a real pleasure to work with them.
Great. Fantastic. Thank you so much. So there you have it. Everything you ever wanted to know about vaccinating children and adults with rheumatic diseases. Now let's get to work and make sure that it happens. Thank you all for listening, downloading, subscribing, and rating our show. Be sure to follow us on Facebook and Twitter at ACR Rheum. And as always, please stay healthy.